usually I find 1201 to 1202 is the point of maximal in as you see, the counter is increasing by the second. For Dr. Sinnott, I'll put the painting right next to Will Harris up here. So I'll have two of my favorite people in the world, up there, which is, well, actually, Dr. Sinnott's not in the picture, so we need to put Dr. Sinnott. I need to put Dr. Sinnott up here, and then his painting next to it. So I'll work on that background, Dr. Sinnott. All right, well, we're about to hit 12:02, so we just have. So I'm going to go ahead and introduce our speakers for today's grand round. So welcome to the Roy Benke Department of Internal Medicine Thursday grand rounds, as Dr. John Sinnott calls it, the best happy hour in Tampa. And we have two wonderful speakers today. I'm first going to introduce Dr. Stacy Bagrova from actually Bagrova. I'm sorry, Dr. Stacy Bagrova, correct? There he goes, Dr. Stacy Bagrova. Stacy is a graduate of the University of Florida College of Medicine, where she was an AOA selection, and she won two of the most coveted medical student teaching awards, which I might mention that I did not win during my time at the University of Florida. So after her incredible time at the UF College of Medicine, she went to Duke, where she was an internal medicine resident at Duke and a superstar there, and then came to join our rheumatology fellowship here in Tampa, joining Dr. Joanne Valeriano Marcet, Dr. Larry Young, and Dr. John Carter, amongst others here, and Dr. Sukari, of course, who had preceded her in coming to coming here to USF as a faculty member from UF. Stacy, in her short time, has already 7 outstanding publications and 4 poster presentations, 2 of which garnered second place in the respective competitions in those society meetings. She's joined today by someone else who spent some time in the Durham area at the time that Stacy was there, and that is one of our newest nephrology faculty members, and that's Dr. JiA Yi. Dr. Yi, another distinguished medical student. She graduated with honors from the University of Tennessee Health Science Center in Memphis, where she held down no fewer than 3 scholarships during her time in medical school. From there, she decided to go to the University of North Carolina at Chapel Hill, UNC Chapel Hill, where she did both her internal medicine residency and her nephrology fellowship. And during her time there, already started with her very impressive publication list, which included a national presentation on lupus nephritis in San Diego, representing UNC. Actually, she made that presentation when she had already joined our USF faculty based on some of her previous work, but that presentation was actually made as a USF faculty member. So it's a delight to have Stacy and JiA presenting this. Today's topic, it's a great title. It Takes a Village, Updates in Lupus Collaborative Care. And we're going to let our 2 superstars take it away. Thank you very much.
Thank you so much, Dr. Lozama. This is a very nice introduction.
Very, very flattering. We were not prepared.
We're very red now, so we're going to start. I just want to remind everyone to please join our Poll Everywhere poll so you can participate. Really want this presentation to be interactive, but not have to call on anyone. But please join us. If you have any problems, let Jennifer or us know, or make a comment. Unfortunately, Poll Everywhere uses full names, and my name is kind of hard to enter. It's in the email, so you can just copy it, or you can use the QR code if you want to scan it with your phone, and that should work, or you can plug it into your computer browser too. Okay. We already had a thorough introduction. We have no disclosures. And we're going to start. So our learning objectives, we're going to describe the clinical features of lupus, identify those indicative of serious organ involvement. We're going to talk a little bit about the current backbone of lupus therapy, including some notable side effects and medication monitoring.
We're also going to highlight some of the more recent advancements in SLE treatment and how these medicines are integrated into the backbone. And then finally, and what we really want to emphasize on is the role of primary care in lupus care and how really everything should be multidisciplinary and how primary care and preventative care is so incredibly important for our lupus patients and can make a huge impact in their overall quality of life.
And as we've mentioned, we'd like to make this presentation very interactive and patient-focused. So we are going to start by meeting our completely made-up patient. There is no PHI here, Alice. Alice is a 19-year-old cis female, goes by she, her pronouns. She's a college freshman at USF. She's very healthy, but she's coming in for evaluation of chest pain. 5 days ago, she stopped training for her track and field tryouts because she's having sharp pain in her right lower chest when she tries to run. It also hurts her to take a deep breath or lie down in bed on that side. She has not taken any medications for this pain, and she's very concerned that her physical activity is being limited because joining track and field is very important to her. On review of systems, she endorses severe fatigue, 10-pound unintentional weight loss in the past month. She's having some drenching night sweats at the same time each day. She has morning joint aching that improves throughout the day, and she has noticed occasional red facial rash, dry eyes, and her dentist commented on dental caries, which is unusual for her age. She denies fever, hair loss, vision changes, mouth sores, hematuria, frothy urine, finger color change in the cold, or history of blood clots. She has never been pregnant, has not had any miscarriages. Her family history is significant for thyroid disease in her mother and multiple miscarriages in her older sister. She does not smoke, drink alcohol, or use illicit drugs, and she is not currently sexually active.
Her vitals are only notable for a low-grade fever, and on her physical exam, she otherwise appears well. Her ENT exam is notable for an aphthous ulcer on her hard palate and decreased salivary pooling. Her chest is overall clear, except she does report pain with deep inspiration while you're doing the exam. Her cardiac exam is notable for tachycardia, but overall regular with no murmurs or rubs. Her abdomen is soft, non-tender, without any masses. Her musculoskeletal exam, she has notable tenderness to palpation and mouth swelling over bilateral wrists, as well as her second and third MCP and PIP joints bilaterally, as well as her right knee. Her skin is notable for erythematous plaque going across her cheeks and across her nasal bridge, and importantly, sparing her nasal labial folds. Her neuroexam is overall normal. Her labs initially are notable for some leukopenia and anemia with a notable ALC decrease. Her BNP, thankfully, is normal. And her liver function tests are within normal range as well. So you do an additional, general chest pain workup, including a chest x-ray and EKG. Her chest x-ray is notable for an infusion on the right side, and her EKG is otherwise normal. Oh, needs to reset.
We reset it before. I'm not sure if people are participating already because this is, no, the poll has been reset. So it looks like some of you have joined and are already participating. So please keep, answering. So we'll give, while the numbers are increasing.
Some people were answering based off of excellent context clues.
We appreciate the participation, though. This is much better when people participate early than not at all.
Yes, please. And this is a good test of the system question.
Yep.
Can give it a few more seconds. It looks like everyone is pretty unanimous that, of course, this is a talk on lupus. So we expect her to have lupus.
There's a little bit of a giveaway there in the
title.
Yeah.
Okay.
You needed to have added Kikuchi Fujimoto as a diagnosis.
Right. Well, sure. That could be on the differential. Not a lot of lymphadenopathy though. All right. And this is a slightly harder question, and we intentionally threw in a bunch of labs because right now, there's so many labs that you can order, and how do you even choose which ones to do? And we're going to talk through all that, but just give us what you think you would do for this lady. And we appreciate everyone's participation. This is awesome.
Oh, I love this real time.
Yeah.
Percentage reporting. So ANA is winning. Wonderful. Nobody's going for your 1433 protein.
Someone knows what this is. I specifically. This is a complicated one with a lot of answers, so we can give some fun.
I thought things were settling out.
All right, sounds like things are no longer changing. Thank you so much for participating. This is great. Now we're gonna discuss all these antibodies. We're gonna start with the ones that are correct, the ones that we would order. So certainly ANA with titer and pattern have one. This is required for lupus diagnosis. So this is definitely the correct test to check here. And then, just ANAs in general, they're anti-nuclear antibodies. So this is a collection of antibodies against nuclear antigen. And there are antibodies within that umbrella that we can check as well, that we can see in lupus. Antibodies like SSA and SSB. The patient did report some dry mouth. She has dental caries at 19 years old. So reasonable to suspect Sjogren's, either primary, coexistent with lupus, or secondary to lupus. So SSA, SSB antibodies are definitely good to check here. Smith and RNP antibodies are also very specific to lupus. You can check them, usually the way they're reported is there's Smith, RNP, and Smith and RNP together because the antibody, they share a subunit to which the antibody can bind. That's why you usually see three things there. Double-stranded DNA is also very specific for lupus. And unlike a lot of other antibodies that we check once and we know they're positive and we don't have to recheck them again, double-stranded DNA can actually change with disease activity and specifically associated with renal disease. So this is a very important antibody to get. Then we want to check complements. They tend to go down in lupus activity because this is an immune complex-driven disease, right? So you have an antibody, an antigen, some complement in there, and all that big gunk of stuff tends to settle down in the blood vessels, cause a lot of inflammation, a lot of problems. So we want to check complements. In addition, we want to check their antiphospholipid antibodies. This is important for lupus diagnosis. It's a part of diagnostic criteria, which we will talk about shortly. We also need to know whether patient is APS positive, especially for women who might become pregnant. And, if we find a blood clot, this is also very important. And finally, we do want to get a urinalysis and urine protein and creatinine to monitor for renal involvement because it may not necessarily be symptomatic, and we can see patients not have, a lot of other clinical symptoms, but they do develop lupus nephritis, and we want to pick that up as early as we can. Some of the other stuff, rheumatoid factor and CCP, sort of either yes or no. You can have overlap of rheumatoid arthritis and lupus, and she did have some joint symptoms and some swelling. So it's okay to check those, or it's okay to defer to rheumatology if you're not sure. Some of the ones that we don't need to check at this time. Myositis antibodies like anti-Jo1, she doesn't really have myositis symptoms right now or rashes that would be consistent with that, so that's not necessary. Anti-gliadin antibodies is celiac disease antibody. She doesn't have any symptoms of that. Anti-GAT65 is type 1 diabetes antibody. You don't need to check that. Scleroderma antibodies are also not necessary to be checked because she does have some dry mouth and some dental disease, but otherwise nothing else that's going for scleroderma. And if you have scleroderma developing in a young woman like that, usually it's pretty aggressive and they have skin changes and lung disease, and it's not really bad Raynaud's. It's not subtle. 1433 protein that no one checked, probably because no one except rheumatologists know what that is. It is a marker that can be seen in really early rheumatoid arthritis. Certainly no reason to check it here. HLA-B27 is also not necessary in this case, as she's not really having any symptoms of inflammatory back pain or any psoriasis, enthesitis, anything that would suggest spondyloarthritis. And uric acid is also not necessary, as one, it would be very unusual to have gout in a 19-year-old woman, and two, she's not really having symptoms of gout either. All right, the key here, and the reason why we wanted to do it in this order is that there are so many blood tests that are available in rheumatology, right? But there's no such thing as, full rheum workup. It is all very driven by history and physical exam, and history and physical are the most important tests to check in rheumatology. And then based on your suspicion of the disease, you check the antibodies to confirm that. And for the interest of time, we're not going to do that, but I do have an educational website called RoomSim. I make no money from it, so still not a disclosure, but I do have a full tutorial on what antinuclear antibodies are, how to interpret the different pattern, and how to interpret different antibodies. So check it out. It's roomsim.com. Very easy. And now we're continuing with the results for Alice. So her ANA is 1 to 1280 in a homogeneous pattern, which is a very high titer. She does have positive Smith and RNP, SSA, double-stranded DNA, and lupus anticoagulant. Her complements are mildly decreased, and her urinalysis and urine protein to creatinine ratio are normal. And we have a very helpful picture of urine microscopy here, which Dr. Yu will explain to you.
So this is really just a reflection on the spectrum of normal for urine sediment analysis. You as a PCP have gone above and beyond and spun down her urine and looked at it yourself in clinic. And all you really see are these kind of shadowy, hazy, cast-like structures. And these are just hyaline casts, which can be seen within normal urine.
All right. And it seems like, you guys kind of unanimously agreed that Alice had lupus, and that's what it's looking like. But let's go over the ACR-Euler classification criteria. Those were released in 2019, and those are the ones that are used for clinical trials, but we also use to help us with the diagnosis. So the entry criterion is ANA positivity of 1 to 80 or more. Right, so this is important. A titer of 1 to 40 is considered negative because it's just so small. And up to 30% of people, especially women, can have a positive ANA of 1 to 160 or less. So it's very common, and the presence of ANA itself does not mean that a patient has lupus. That said, the absence of ANA means that this is not lupus, and you need to look for something else. That said, if you do have ANA greater than 1 to 80, you go down to additive criteria. And there are a lot of those. And in order to diagnose lupus, you need a positive ANA of greater than 1 to 80 and 10 points from the entry criteria, from the additive criteria. Now, our patient has pretty positive ANA. She has fever, leukopenia, oral ulcers, pleural effusion, joint involvement, lupus anticoagulant, low complements, and anti-Smith antibody, and a double-stranded DNA antibody. So she has way more than 10 points and a positive ANA, so she meets the classification criteria for lupus. Do want to say one word on classification criteria. It can be very helpful, especially for residents and medical students, for learners that are trying to figure out what are the most common manifestations of diseases. They're not necessarily used for diagnosis. They're used to homogenize patients in clinical trials. But again, they can be important. They can be helpful. They're not end-all be-all for diagnosis. All right. And
so moving on to the next question. At this point in time, what do you guys believe is the next best steps in management? This is a multiple answer, so you can pick as many as you feel is necessary. Love that referral to rheumatology. It's getting a lot of love. That's it. Okay, so talking through each of these options, first and foremost, she's showing active disease. So starting off with an oral course of steroids can help give her some symptomatic relief now. And of course, you always start prednisone with an intention and an end date in mind. So you should always do it with some kind of plan for taper, never really indefinitely. Referral to rheumatology, of course, long term, she's going to need follow-up, she's going to need care. But the main important thing is, as everyone knows, it can take time to get a rheumatology appointment, especially when, she doesn't have any other indication to be admitted. So it's also okay to go ahead and do the prednisone and while you're working on getting her established with rheumatology. Colchicine in this instance, maybe if she had some signs of pericarditis, we had an EKG that would say otherwise. And really, in this instance, we don't really use it for pleurisy. Hospital admission and IV steroids, we really try to save those for evidence of end organ involvement. And at this time, it's primarily skin and joints and her effusion as well. So at this time, we wouldn't necessarily consider that. And of course, given her BNP and her urine analysis and urine sediment look good, NSAIDs can help, especially with the pleurisy and the pain associated. But due to GI issues, we wouldn't necessarily put that together with prednisone. Okay, next question. Which steroid-sparing medication should be started? Because of course, steroids are not a long-term answer. You got to put something else in the mix to keep them controlled without having to use steroids. Okay. Everybody's picking plaquenil? Really?
Or maybe it's just one person.
No, nothing?
Okay.
Unanimous.
Love it.
Very
I
good,
love
very
it that
good.
no one kept just keep her on low dose steroids though.
Yeah, that's good. That's good.
All right, so now we're just going to talk about some lupus treatment options, and I'm going to start with the queen of lupus therapy, hydroxychloroquine, also known as Plaquenil. So you guys, I'm sure all know this used to be an anti-malarial drug, doesn't really work like that anymore, but it works beautifully for lupus. And this is the only drug that has been shown to actually improve mortality in lupus patients, and it also has been shown to prevent flares in lupus patients, which we know there have been studies done looking at stopping hydroxychloroquine, and the group that had hydroxychloroquine stopped had many more flares than the group that continued it. This is a very well-tolerated medication. It doesn't actually suppress the immune system, which is a big concern for our patients right now because COVID is better, but it's still ongoing. So a lot of patients ask about that. It doesn't really require any lab monitoring either, which is very convenient. It does require a yearly eye exam because with a long period of time, hydroxychloroquine can accumulate in the retina. It can cause some problems, and very early changes can be picked up on regular exams. With ophthalmology, there is also a concern that I think, all learn about, maybe studying for step 1 or in residency or in med school, about QTC prolongation. And that's really been studied well recently with hydroxychloroquine, unfortunately, being used for COVID treatment in the beginning. But it's been shown that really, unless the patient is on multiple QTC prolonging agents, in and of itself, hydroxychloroquine really does not prolong QTC interval all that much. So we don't generally monitor EKGs or anything like that. In patients who have, really bad kidney disease or on dialysis, we usually decrease the dose and maybe give it 3 times a day because it can cause some GI side effects.
3 times a week.
Sorry, not 3 times a day, 3 times a week. Yes, yes, we'd never give it 3 times a day. 3 times a week, usually like Monday, Wednesday, Friday, or whenever they have their dialysis for convenience. In very rare cases, it can cause some myelosuppression and can cause some heart disease, but again, it's really rare, usually from using too high of a dose, and I would limit the dose to 5 milligrams per kilogram to prevent ocular toxicity. So this is really the best drug. I'm so glad that you guys all picked it. It would be very appropriate to start it in this patient. Azathioprine is also one of the drugs that we use with lupus. It can help with various manifestations, including kidney. It doesn't work as well as some of the other medications that we now have available. It can cause very significant immunosuppression and agranulocytosis. We generally check patients' TPMT level before we start azathioprine because low level increases the risk of agranulocytosis. It's a medication that we use sometimes. We don't love it because it tends to have, some serious side effects and doesn't work as great as some of the other ones, but it is an option.
And then kind of one that's come into popularity as of late is the CellCept/Myfortic category of immune modulators. These are particularly helpful in individuals who have some type of renal involvement, regardless of the subtype. Overall, well tolerated. There are people who have GI distress when taking this medicine, especially in the CellCept variety. So you'll commonly see us switch people to Myfortic, and they actually do much better. It is also common to, use some type of GI prophylaxis with it as well to help with the GI tolerability. This is another medicine we have to watch for leukopenia, so you'll see us checking CBCs intermittently for this, as well as LFTs to both monitor before and during therapy. This was one that is absolutely contraindicated in pregnancy, so you'll see us talk about, planning as well as birth control in these patients, just because this is such a contraindicated medication. Another reason why we switch patients to azathioprine from CellCept is for this very reason, either in anticipation of pregnancy or because they were pregnant and we have to make the swap quite rapidly. Another medication that I think we should be using more and probably hesitant to use just because of the drug monitoring associated with it are the calcineurin inhibitors. In the realm of lupus nephritis, these are particularly helpful for people who have proteinuria because independent of their immunosuppressing effects, there is also some benefit in terms of how this medicine works to stabilize the foot processes and kind of minimize the proteinuria that comes with it. You know, that mechanism extends to other causes of proteinuria as well. As many people in the transplant world know, these medicines require a lot of close monitoring. Dosing is very, very different from patient to patient. You know, these are dependent on various types of metabolism, so not everyone is the same. The drug monitoring requires very specific lab timing, which, you know, can be difficult to obtain depending on a patient's schedule, and always have to be interpreted with a grain of salt. You know, you really got to know the timing and the dosing in order to interpret a drug level correctly. But these are good adjuncts, especially in the setting of pregnancy.
Rituximab is sometimes used in lupus. Before rituximab trials were done, we had great hopes that this medication will work because lupus is a B-cell driven process, so depleting B cells thought to be very useful. However, unfortunately failed in most trials and doesn't really change the disease activity very much. Doesn't work in renal disease as well as some of the other ones, and we now mostly use it limited to hematologic disease. So if patient has autoimmune hemolytic anemia, for example, as a result of their lupus, rituximab can be very helpful. And sometimes if patients have failed everything else and there's nothing else we can do, we would give them rituximab, and some patients certainly respond, but we generally, reserve it for kind of very special cases.
And then finally, probably the most potent out of all of these classical options is Cytoxan, so IV cyclophosphamide. This is particularly notable, and we'll talk about this a little bit down the road, but for people who have severe end organ involvement. There's a lot of toxicity associated with it. I'm sure many people from many subspecialties are familiar with the consequences of this medication. I will say our dosing in lupus is in a different realm from cancer. So we're talking about doses kind of in a different order. So it's not as notably toxic as our oncology colleagues are very familiar with, but is very effective, especially for the people who have a severe amount of disease activity.
And then there are some new drugs on the market that have come up in the past few years, one of which is belimumab or Benlysta. This is a medication that can be given IV or sub-Q. It has first been shown to be beneficial in non-renal lupus, like skin and joints and other manifestations. And then there have been trials that showed its success in lupus nephritis as well. Notably, it has not been studied in CNS disease in lupus, so lupus erythematosus, and some trials have shown slight increase in depression and suicidality in patients who are on belimumab. So important point to screen patients besides just increased risk of infection and their basic labs is to screen them for depression before starting. We always ask about this, and then see how patients are doing while on this medication. Me and my colleagues haven't seen it a lot in our clinical practice, but I've certainly had maybe one patient whose depression is significantly worsened while on belimumab. Anifrolumab is probably the latest drug that has been FDA approved for lupus, also known as Saphnelo. Another drug that was really, really exciting before it was studied because it actually affects the mechanism by which lupus is driven. It's an anti-interferon drug, and interferon is very important in lupus pathogenesis. That is actually part of the reason that hydroxychloroquine works, because it prevents interferon formation at the plasmacytoid dendritic cell level. For those of you who are immunology nerds, which probably none of you except for rheumatologists here. So anifrolumab was really exciting, but it showed some effect in clinical trials. It was not dramatic as we would expect, and it has not been studied in severe lupus nephritis or, again, in CNS disease. So we generally use it in patients who cannot use some other medications, have gone through many different things, and are still having pleurisy, joint pain, joint swelling, things like that. It's also extremely expensive because it's recently been approved. So really a very limited number of patients would be candidates for this.
And then finally, kind of one of the newer ones that have entered the sphere this past year is voclosporin. As the name would imply, it mechanistically is the same as cyclosporin. These are CNI-based medications. The Aurora trial, which was the major trial in lupus nephritis, just came out, in the last about 6 months at this point, and did have some beneficial effects. The dosing of it is lower, so you'll see the milligram quantity is going to be much lower than cyclosporin, and it's a fixed dosing. So hypothetically, the binding specificity of this medicine is better than cyclosporin, meaning you can use lower amounts and get away with having the same amount of effect. So from a practicality perspective, of course, it's easier to use than something like cyclosporin, which you do have to monitor for drug interactions and drug dosing levels. The problem, like all of the new player medicines, is it's brand new, it is not generic, it is very expensive, and doubly difficult is because there are somewhat equivalent mechanistic drugs that are already on the market, have been on the market for 30 plus years at this point. It is difficult to convince insurance to give this one a whirl. So hopefully down the road, as they're more used and they have a longer track record out on the open market, maybe that will change. But for right now, it still has relatively limited usage.
And I just want to make a point here that we want to use DMARDs in really all rheumatologic diseases, including lupus, in order to minimize the use of steroids. There are more and more studies coming out that show that a lot of morbidity and mortality as lupus is actually related to steroid usage. And steroids are the most immunosuppressive drugs that we have because they suppress everything. They can increase the risk of cardiovascular disease, diabetes, weight gain, osteoporosis. Patients with lupus very commonly get a vascular necrosis, which is so debilitating and so horrible to have for a young woman. They can get eye disease. Even the lowest doses of steroids can still lead to cataracts and glaucoma. So these are important drugs. They can be very helpful. They can be life-saving in the correct situations, but we have to be very, very mindful and reassess, do patients still need the steroids? How do we decrease their dose? How do we get them off? Now, rheumatologists are often thought of just these sort of steroid dispensaries, right? But we're also trying to be really, really thoughtful and really, really careful and be very responsible for using these drugs, just as our nephrology colleagues as well. All right, here's a really useful table from EULAR, European League Against Rheumatism, which is a really awesome name too, but this is just a summary of lupus treatment. Dr. JiA and I did disagree with some of these grade recommendations, especially for belimumab. It has some good data with it, not as good as, say, hydroxychloroquine, so maybe we wouldn't make it green, but don't focus on the colors as much. It just kind of helps show our stepwise treatment. So for mild disease, we would use Plaquenil, maybe steroids if needed for a short period of time, and then try to get patients off. For more refractory disease, especially if joints are involved or a lot of pleurisy, we could do methotrexate. We could add on azathioprine as well, still keep the hydroxychloroquine. And then for disease that's a bit more moderate, we could add on belimumab. We can use the tacrolimus, cyclosporin, voclosporin, maybe. We could add on Cellcept. And then for really severe cases like really resistant lupus nephritis, cerebritis, diffuse alveolar hemorrhage, we would use cyclophosphamide. And in refractory cases, just reach for rituximab because there's nothing else that we can do. And we want the patients to be in remission, which is also does not have an exact definition of what remission is, but we want their disease activity scores to be as low as possible. We want them to be on no glucocorticoids. We want them to be on Plaquenil if they can tolerate it, or get those disease activity scores and steroid doses to as little as possible.
So, Alice follows up 3 months later. She got established with rheumatology and she's completed a short course of steroids. She was started on Plaquenil and actually says she feels good. She's expressed concern for steroid side effects, especially long-term, and would prefer not to use this medicine again. She's feeling better. She's running track and field again, and she's excited to tell you that she's in a new relationship. So at this time, what other aspects of healthcare maintenance should be addressed? Love that early vote for vaccination. Wonderful, wonderful.
This is like the most exciting part of
I know. Loving something interactive. Okay. In the interest of time, we probably have to continue, but as always, there's no one right answer.
All right, so we'll start with vaccinations, which was the first thing that you guys have picked, and that's absolutely correct. I think vaccinations have been in our mind, and then the minds of our patients much more in the last couple of years than they have ever been. So obviously, all patients who are on immunosuppressive medications should get the vaccines that are recommended for general population, like yearly influenza vaccination, with the caveat that they do need a high dose. They should get their COVID primary series, whichever one, do they choose Pfizer, do they choose Moderna, and get all their boosters. And I'm sure you guys have experienced this along with us specialists, that the boosters have been coming out at a crazy rate. There are different recommendations, and American College of Rheumatology has been really good at updating their guidelines for boosters. So if you guys have patients with rheumatologic diseases and you don't know when they should get a booster, you can check that out, or you can always reach out to your friendly rheumatologist, including me, and ask, and we're happy to guide you through it. There are some additional vaccines that patients should get because of their impaired immunity that they may not even qualify by age. For example, like pneumococcal vaccination. We would prefer the patients to get it before immunosuppressive treatments are started. And a caveat, so now there's the new PCV20 vaccine, right? And we don't know if any more boosters will be needed. So that's a good candidate. And maybe some of my patients have been convinced to get it because it's just one shot. But for those who are getting the 2 series, they need a rebooster with PPSV 23 every 5 years. They need zoster vaccine series, and we've certainly seen our patients who are immunosuppressed get really, really severe disseminated zoster, and then post-herpetic neuralgia. So if you can prevent it, that's great. A lot of our patients are younger, so they would be of an age where hepatitis B vaccination is just given to all newborns. However, we do need to check their hepatitis B status before giving any immunosuppressive medications. And if you see that their surface antibody titers are low, then considering a booster would be very helpful. And then men and women or individuals of age 26 to 45 should get an HPV vaccine as well. That age has recently been extended, right, from 26 to 45. So definitely discuss this with your patients. And then a note on live attenuated vaccines. Generally, they're not recommended, right, because patients who are immunosuppressive medications may actually get the disease from the live attenuated vaccine. However, if they have good disease control, and if they have a good reason to get that vaccine, like they didn't get it in childhood, or they're traveling, they could spend time in a country where that vaccination is recommended, and they're at high risk of getting the disease, there are ACR recommendations for holding immunosuppressive therapies. And again, you can reach out to your friendly rheumatologist to help you with that, or you can look those up as well. This is just an example of some medication management with the vaccines, right? So we give patients medications that suppress their immune system, which also as a side effect means that they will not respond to vaccines as well when they're on these medications. The worst one by far is rituximab, and that's really been studied heavily in COVID, and patients just do not respond to COVID vaccination or flu vaccination quite as well. So here are some of the recommendations on the left-hand side. We recommend holding methotrexate for about 2 weeks after the vaccine. Rituximab, we really try to time the vaccines 2 to 4 weeks before their next infusion, because at that time their CD19 cells, CD20 cells should start coming up, and they should be able to have a robust response before getting suppressed again. And then other immunosuppressive medications can be continued, but again, a discussion with the rheumatologist can be helpful. And then we want them to be on as little steroids as possible in general, but if they're on more than 20 milligrams of prednisone, we would defer vaccines other than influenza. These are the recommendations for COVID vaccines. This is complicated. I'm not going to go through everything. I would point out again, hydroxychloroquine is the queen. You don't have to do anything. You don't have to change any timing. You can just get any vaccines when they're on it. Some of the other medications do require holding the drug for some time after getting the vaccine, and it's very reasonable to just tell the patient to discuss it with their rheumatologist. Or if you guys want to give the vaccine, just reach out to us and let us know, and we can guide you through this.
Some other healthcare maintenance things, and this was addressed in the question as well. Cervical cancer screening is very important, and it's of note that patients with lupus who are on immunosuppression, you really should treat them akin to HIV positive women. There is a higher incidence of cervical cancer. Bone density, that becomes really important to monitor if they've been on a prolonged course of higher dose steroids. Mammography at this time for her age, she doesn't qualify. So your usual age-based or family history-based screening protocols would apply. Depression screening, of course, everyone should, honestly, but especially for our lupus patients, not only in the instance of Benlysta, but also you can think about it, a young adolescent person going through a major chronic illness. There's a lot of stressors, and there are a lot of other, just kind of growing pains and growing up issues that they deal with as well. So adjustment and adaptation to this diagnosis can be difficult. So even outside of belimumab, it's important to support these patients as much as you can and really try to push them towards having some regular therapy and regular contact with people to talk about these changes. Contraception counseling, we'll talk about this, of course, in more detail, but absolutely, I found myself doing more contraception counseling as a nephrologist, I think, than I had ever expected to. And that really comes down to the medications we give, as well as the fact that, vast majority of lupus patients are female, vast majority of them are in reproductive age, and vast majority of them want to continue with all their other life goals, and they really don't want to let their lupus be the one thing that kind of stops, lifelong aspirations. So it's very important to bring this up. And of course, we really need our PCP and GYN colleagues to assist with this, because the exact dosing and the exact options, that's a little bit outside what we do in our subspecialties. And then the last thing is photoprotection, and not only from the perspective of people being sun sensitive. So some people's lupus have very sun and UV sensitive rashes that can come up with sun exposure, but also all of our immunosuppressant medications put these patients at higher risk for all types of skin cancer, especially if they're already more fair to start with. So really talking to them about, block choices, clothing, being on top of their skin cancer assessments and skin exams, that all is very, very helpful.
And I just want to make one more point on depression. It has been shown that lupus in and of itself, affects the brain, affects the central nervous system, not only in encephalitis type of way, but also does increase the risk of depression, anxiety, and other mental health disorders. And unfortunately, none of our immunosuppressive medications actually treat that. So the recommendations for treatment are the same as anyone who doesn't have lupus, right? Like Dr. JiA had mentioned, counseling, maybe some medications in short term, and keeping follow-up with this and making sure to address that. But the patients with lupus are certainly at higher risk of that. UV exposure actually causes oxidative stress and can increase the risk of flares in lupus. So it's very, very important for patients who even those that don't have a rash, to use photoprotection to try to avoid this, and especially in Florida, right? And I just want to mention one more thing that's not on here, but I just really want our primary care colleagues and cardiology colleagues to think about that patients with rheumatic diseases are at much higher risk of cardiovascular disease than their age-matched cohorts. Even if you control for every single risk factor, including diet and weight and cholesterol, still patients with rheumatic disease are at higher risk. And studies have shown that the average age for a woman with lupus to have a heart attack is in her 40s, right? Not the population you would really think about that would have a heart attack, but I just want you to keep that in mind. If they're presenting with, some sort of cardiovascular symptoms, chest pain, stroke symptoms, take them seriously. Just because their age is young doesn't mean that they don't have that. And again, not applicable in 19-year-old women, but maybe in women, over 30, over 40, a CVD risk score actually does not account for the risk associated with rheumatic disease or HIV for that matter. So it's important to start their statin starts their cholesterol management early, even if the risk may not be that high. And they're trying to come up with a new score that would account for this. And so far, all of the attempts have failed. None of these scores work and have been validated, but the work is ongoing. And in the meantime, it was just sort of your clinical gestalt and knowledge about the risks that these patients have. All right. American College of Oncology released very, very helpful reproductive guidelines in 2020. They have all these beautiful tables that you can refer to that really can guide your contraception counseling. I have printed this for my patients to give it to their OBGYNs or to their primary care doctors, so just keep it with them so that they know. So basically what you need to know before starting patients on contraception is knowing their antiphospholipid status. If they have positive antiphospholipid tests, like Alice does, we would recommend avoiding estrogen, basically. So IUDs would be preferred because they're a very reliable method of contraception, right? Or progestin-only pills, which are obviously less effective, have to be taken at the same time and very cumbersome, but some patients do not want an IUD, so that could be an option for them. Point is, avoid combined contraceptives that have estrogen in them. If they don't have antiphospholipid positivity and they don't have lupus, then basically kind of everything is on the table. If they do have lupus and they have low disease activity or high disease activity, try to avoid estrogen patch. But oral contraceptives are fine as long as they don't have the antiphospholipid positivity. And that's another reason to kind of check it up front at the time of the diagnosis. And they, with high disease activity, they're probably going to be on medications like mycophenolate or something teratogenic. So as Dr. Yi had mentioned, you have to be, very thoughtful and try to give them some really reliable methods of contraception, like an IUD. And we generally, in patients who have high disease activity, they're probably on steroids for a long time, and they're at risk for osteoporosis, and we don't want to give them a depot Provera shot with that because it also increases risk of osteoporosis.
We talked about a lot of this already in terms of photoprotection, but just a couple of reminders. Make sure to educate them on getting products that give you both UVA and UVB coverage. In the US, the labeling can be a little bit confusing on that matter. The other thing to pay attention to is amount. We never put on enough sunscreen, I don't think, and the frequency of reapplication, especially if they're going to be outside for a long period of time. It's always more often than they actually think it's going to be. Vitamin D is also something that you should consider monitoring, supplementing, especially if they're on steroids for a longer period of time. And then the final thing is, send them to dermatology for concern, have them to be aware of their skin, and even to get annual comprehensive skin exams just because of that skin cancer risk while they're on immunosuppression. So, Alice talks you talk to Alice about all these healthcare maintenance measures. She agrees to start using sunscreen and will start taking a multivitamin with D3. She would like some more time to read and learn about these vaccines, so she'll come back to you with an answer about them, and is interested in getting an IUD placed for contraception. She will talk to her gynecologist about this. In the meantime, she agreed to use condoms, given she is in a new relationship. So we built in some time for questions. I will say we are running behind. So please feel free to email us or put the messages in the chat. We'll spend some time afterwards replying and getting all those answered. So Alice, goes on with her life, gets a little bit lost to follow-up, which is not uncommon in our patients of this age range. She initially felt well, so she continued with school, continued with her sports, and got really busy and couldn't see you. Today, she's coming back because she feels tired. She's having night sweats, low-grade fevers, facial rash, joint pain, all the symptoms again. But this time, she's also has swelling throughout her body. For once, she's hypertensive. She has the same plaques on her nose and her cheeks, but this time also has pitting edema as well as her joint swelling. You redo the initial test, but now her urine shows she has proteinuria and hematuria. Her creatinine is also now 1.3. Before, just as a refresher, it was 0.8. Her urine protein creatinine ratio now also is positive, notably positive, at 6.8 grams. She is again leukopenic and anemic, and then the rest of her labs, like always, is pending. This quick little image on the side is just an example of an RBC cast. Just so you guys know, it is difficult to distinguish. You got to really squint a little bit. But when you're looking at this under a microscope, kind of try to look and see whether they have kind of a donut indentation in the center. The middle one, I wish I can point, the middle one is probably the best example of it to distinguish from like an RBC cast where you can actually see some of the granulation and nuclei that come with a PMN. Okay. Same question again. What is the most appropriate next step in management? Select as many as you want.
Actually, I think this is just.
Oh, just one?
This is one.
This is one.
Trying
Okay.
to make
You got to pick one.
You got to pick one.
one.
And some of these sort of require the other one to be on board. Like, in order to pulse someone with IV methylprednisolone, can't really do that in clinic.
Although some people with really good infusion centers, you can make it happen.
That's true. That's
You
true.
can make it happen.
Wouldn't recommend it. All right, and it sounds like everyone is sort of, okay.
Okay. You can do a kidney biopsy outpatient. It does exist.
Can do that. But I think the point we're trying to make here is that for the majority of our patients, with the current state of healthcare in the United States, which this talk is not about, so we're not going to go into that, it's really hard to arrange all the necessary actions outpatient. So really the best thing for her to prevent her from getting worse and to treat her quickly and to do everything is to just admit her to the hospital and get her seen by rheumatology and nephrology and get all the care that she needs in a very short period of time.
So that's exactly what you do. You get Alice direct admitted, thankfully bypasses the ED for once, and consult nephrology and rheumatology. She started on IV steroids and then prepared for renal biopsy the next morning. The renal biopsy is very important to obtain in someone who has a concerning urine, mostly because it not only gives you a diagnosis, but it quantifies both severity and chronicity, which are very important factors in deciding how aggressively we want to treat this. And it's totally okay to start the steroids ahead of time, especially if you can get the biopsy the next day. Becomes a little bit more hairy, if your biopsy timeframe is a little bit more further out. But in general, you want to get the disease control going as soon as possible.
And that's actually another reason to admit them to the hospital and get the biopsy as soon as possible, because then you give them steroids and 3 weeks later they get the biopsy.
You might cloud a lot of your diagnostic yield there. So the lupus nephritis classification is the WHO classification. I can't say it's the most logical. They built it according to pathology, and that's what we'll go by. In general, it's classes 1 through 5, with 5 being a little bit of a, diagnostic outlier, and then 6, like a lot of other things, is just completely sclerosed, basically near dialysis. There's not much to salvage. So class 1 is minimal mesangial lupus. You can see, this is a beautiful illustration from Dr. Jeanette at UNC. You can see some IF staining kind of scattered throughout the mesangium. You can compare that to class 2, where you have legitimate mesangial, not only staining with immunoglobulins, but proliferation. So in the light microscopic slide, you can see the cellularity that's going up in the mesangial areas of the glomerulus. 3 and 4 are both considered more active versions of lupus nephritis. The main difference is just how many glomeruli on your sample are involved. So less than 50, greater than 50%. And on top of that, when you're talking about class 4, it also divides into predominantly segmental. So part of the glomerulus is involved versus global. All of the tufts and branches of glomeruli are involved. And that goes down to how pathologists describe a lot of these changes. Both of them considered active, and both of them should be treated aggressively. And then finally, class 5 is membranous. And this is in the category in the nephrology world of a secondary membranous. Like all other membranous, you kind of have this lumpy bumping staining along the glomerular basement membrane. And this also is the classic cause of proteinuria, nephrotic range proteinuria for our lupus patients. Our patients' biopsy results are, I think it's the next one, class 3 and class 5. So you can have a combination, and this is important. Class 5 can always come as a side to any of the other classes. Okay. So treatment for end organ involvement, and lupus nephritis is considered that because it is considered a vital organ. The main judgment that we try to make is whether we should use mycophenolate, so Celsep or Myfortic, versus IV cyclophosphamide. I do emphasize the IV part. We really don't ever use PO cyclophosphamide. The major trial for this was the ALMS trial, which came out in 2009, so quite a while ago, and it studied specifically 3, 4, and 5. In general, it was a non-inferiority, so the point was to make that MMF was just as good as IV cyclophosphamide. Of course, you're talking about a very different side effect profile between those two medicines. Outside of lupus nephritis, we also use IV cyclophosphamide when there are other organs that are severely involved, namely the brain, the lungs, as well as in catastrophic APS. The other discussion is how much cyclophosphamide, and we won't get into this too much because it gets into the minutia, but there are 2 different dosing protocols, and it was also defined with non-inferiority, both of them. In general, your lupus has an overall lower cumulative dose for cyclophosphamide, which long-term can be important if you anticipate this person to require multiple treatment courses of IV cyclophosphamide. And then lastly, all the new medications that we mentioned before, they can be used in lupus nephritis. The main emphasis we want to make is both belimumab and voclosporin, they're additive medications. So they will never replace the classics that we talked about before. They're really meant as to be given on top, especially in the maintenance phase of treatment, as opposed to induction.
Okay, and then so just really briefly, just something for you to think about when you guys are inpatient or you're seeing patients in the outpatient setting. Fertility preservation is very important with cyclophosphamide, right? Because it does deplete the the eggs and it decreases sperm production. It depends on patient's age and the cumulative dose. So younger patients who are just going to get induction with cyclophosphamide, if we were to choose that in ALICE, for example, generally lower risk than someone who is for a woman, especially after 35, or who's going to get it for a long time, right? Because we do have a limited number of ovarian reserve, unfortunately. Gonadotropin-releasing hormone agonist co-therapy is conditionally recommended for monthly administration, but in some of our protocols that we use, that's not necessary. There is recommendation against testosterone supplementation in men, but for sperm cryopreservation, and a lot of that was also based on oncology trials, right, and the amount of cyclophosphamide they use there. But the point here is patients should be referred to a fertility specialist, preferably before or soon after therapy initiation. And these are discussions we have to be having with our patients.
So in light of these kidney biopsy results, She is introduced to both IV cyclophosphamide and PO mycophenolate as options. She's always wanted to start a family, so she would really like to avoid anything that can affect her fertility. As a result, she agrees to use mycophenolate and agrees to really look into reliable birth control and talk with her gynecologist about this. She goes home after her IV steroids and is continued on a taper with mycophenolate and, of course, Plaquenil. In addition to this, she started on PJP prophylaxis with atovaquone and famotidine for GI prophylaxis, and both of these are contingent, of course, on her prednisone dose. So Alice returns to clinic 3 months later. She's feeling much better. She's still on her Plaquenil, of course, and has continued with her steroid taper and is almost done. She's tolerates Cellcept, and she's also been started on lisinopril, given her proteinuria. She had an IUD placed, like you recommended, but is also excited to tell you she's engaged and has some serious questions about the future and what it'd be like for her to start a family.
So our next question is, after congratulating her on her engagement, what do you tell her about her disease and future pregnancy planning?
Okay.
Good answer.
Anybody else? Any other opinions? Okay. Continue.
Yep. All right. So pregnancy is definitely possible in lupus patients, especially those without very severe renal disease or other manifestations. And the biggest predictor of poor pregnancy outcomes is lack of planning. So it's very important to discuss this with patients in advance, before they get pregnant and before they even try to get pregnant, and then involve maternal fetal medicine kind of early on in the pregnancy, because they're also really important in management of these patients. The kind of entry criteria for safe pregnancy planning and attempts to get pregnant is that a patient's last flare should be greater than 6 months ago with no recent medication adjustments. And their disease activity should overall be very, very well controlled. Some of the medications that we have to stop are listed on the left-hand side. Before conception, we want to be done with mycophenolate, cyclophosphamide, methotrexate, leflunomide, and thalidomide. So we need to look into alternative options and make sure that patients are doing well on alternative medications before they attempt to get pregnant. At conception, we can discontinue belimumab and rituximab. For patients, for example, with ANCA vasculitis who require rituximab to control their disease activity, we continue it gingerly through pregnancy. ACEs and ARBs should be stopped before conception. NSAIDs can be continued, but they can actually impair the ability to conceive. So if your patient is struggling, consider stopping their NSAIDs, and they have to be stopped before third trimester to avoid premature PDA closure. What needs to be started or continued is, of course, Plaquenil. It actually improves pregnancy outcomes. Like, what a wonderful drug it is. I promise you, Plaquenil doesn't pay me anything. It's an old drug, it's cheap. It's just really good. It does decrease the risk of neonatal lupus in patients with positivity of SSA or SSB, and it actually decreases the risk of obstetric APS as well, or antiphospholipid syndrome. We also now recommend adding a low-dose aspirin in the first trimester for preeclampsia prophylaxis. Just make sure patient doesn't have allergy to aspirin. And we continue hydroxychloroquine. We can continue azathioprine, and that's an option for our patients to be switched for some of the medications. Prednisone, we try to give lowest doses possible, but aiming for less than 20 milligrams a day. And then calcineurin inhibitors can be continued as well. All right. It is also important to think about men with rheumatic disease who are they're an integral part of pregnancy planning. So some of the medications are strongly recommended to continue, conditionally recommended to continue. You guys can look. I want to talk about things that need to be stopped. Again, cyclophosphamide, they will not be able to conceive when they're on this medication. So this needs to be stopped at least 12 weeks prior to attempting conception. Thalidomide also impairs patients' ability to conceive, so that should be stopped at least 4 weeks. And then some of the newer drugs have really not been studied, so we don't know what to do with them. And this is the discussion with the patient. All right. Here are some recommendations in a table format for what to do during pregnancy and before pregnancy. So as we've mentioned, low disease activity is very important. Once they reach that, you can proceed. And these are some of the important points for things that we need to know before patients get pregnant. So first, they need to be on Plaquenil, they need to be on aspirin, we discussed that. We need to know their SSA and SSB positivity if present. The reason why is it can increase the risk of neonatal lupus and congenital heart block. If patients are positive, but haven't had a history of this, they need to get serial echoes. If they have had history in prior pregnancies, that increases the risk in the current pregnancy, and they need to be screened more commonly, and they need to get some dexamethasone. And this is where your maternal fetal medicine colleagues are going to be really helpful, and they're going to be doing these echoes. You also need to know their antiphospholipid numbers. If they don't have any, you can just give them low-dose aspirin. If they have positivity and they've had history, then there's different management. Your hematology colleagues can help with that as well. And then importantly, involve all your colleagues that you need in order to take care of these patients adequately.
So there's a couple specific pregnancy lupus nephritis concerns. Medications we kind of are addressed it. The main one that we add on that's unique are ACEs and ARBs, and this is for the proteinuria management, not for their blood pressure. There also needs to be some discussion about blood pressure if it is present. Ideally, we would switch them ahead of time to either labetalol and/or nifedipine and try to keep the blood pressure controlled throughout their pregnancy. Baselines are really important, mostly because a lot of the symptoms and lab changes that come with preeclampsia or HELP are very, very similar to signs of worsening lupus nephritis or lupus in general. So the MFM colleagues really like us to keep a good idea of what their baseline is before they're pregnant, so they have something to compare to and help decide later, especially in the third trimester, how concerned they need to be for changes. The other thing is, do they have CKD? And this extends beyond lupus, but if they do have CKD, pregnancy itself is a very significant stressor on the kidneys, and there is a degree of both physiologic and probably in CKD pathologic hyperfiltration that comes with pregnancy and only gets worse as the baby gets bigger. And so people with CKD, depending on the severity, may need dialysis to support the pregnancy. And after they deliver, they may or may not need to continue on dialysis, but all patients should understand that their renal function may not return to baseline after this particular pregnancy. Lab monitoring is important throughout, at least every trimester. These are pretty standard. We check them for all of our lupus patients, but doubly important when they're pregnant. And then kind of to keep in mind things that are to be expected with pregnancy. So there are some degree of changes in proteinuria and ESR, as well as complement levels to be expected. And I'm sure everyone knows you get pretty anemic in pregnancy as well. So that hemoglobin will drop.
But those things don't necessarily mean the patient has a lupus flare, right? It just means that they're having a normal pregnancy. So again, very important to know kind of the baselines before patients are pregnant, again, planning for this. And so then you know if it's actually, if they're flaring or it's just a normal pregnancy that they're having.
So you discuss all these things with Alice, and she tells you that she wants to be healthy before she tries to get pregnant. She's very motivated to stay in remission, and she has a good support system in her fiance and her family. You agree to keep discussing her conception timeline as things continue, and have agreed to switch to azathioprine and Plaquenil when the time comes. And kind of on a point, we recommend 6 months, and well-controlled is slightly subjective in some spheres. So all of this just needs to be discussed, and these decisions need to be made together with your patient. You know, everybody has different family planning goals. Everybody is willing to accept a different degree of risk. So all of this needs to be discussed on a case-by-case basis.
All right, so we're finally coming to the end of our talk. Lupus is a multi-organ disease requiring very patient-centered and multidisciplinary care, and we're always happy to help and assist. From diagnosis, treatment, and appropriate preventative health measures are imperative to achieve favorable outcomes in these patients, that they can have very full, very wonderful lives, and we can help them with that.
Yep. Okay, any questions? I know we ran out of time, apologies. We try to talk faster at the end.
Hi, Dr. Yi and Dr. Bagrova. It's Dr. Basil from nephrology. Thank you. It's a great presentation. I mean, it's so unique and has a lot of information, but we really enjoyed it. Just have a quick question, So, I mean, for the long-term, basically renal outcome on nephrology, they still like Cytoxan still, despite all the advances of CellCept and even combining belimumab and other stuff, still long-term as far as dialysis, doubling of creatinine and stuff like that. We have better data with the Cytoxan. And I will argue that low-dose Cytoxan, based on a couple of trials, the Euro-Lupus was mainly for basically different population. There are other trials that showed even if you use low-dose Cytoxan, like the Northeastern basically study. It shows that the 500 is not a lot. And I will argue that, even in young patient, like you suggested in this patient, Cytoxan can put that disease into remission because it's a terrible disease to have. And I would say, still long-term Cytoxan is the best answer. Now, in other diseases, Dr. Yeer, especially you're coming from UNC, like the vasculitis is becoming more pathogenetic type of approaches where we target the complement, where we target receptors on the B cell. How far are we to have a first line, this type of management compared to the vasculitis and other diseases? And thank you.
From a B cell perspective, both rituximab and the other version, obinutuzumab, have been trialed in lupus and lupus nephritis. The outcomes are simply not what we would hope, and definitely doesn't replace IV cyclophosphamide for the really severe cases of lupus nephritis, those that are on dialysis at the time of diagnosis. You're exactly right in terms of the toxicity. We have to keep all the dosing in perspective. And we didn't mention this before, but cumulative lifetime dosing for IV cyclophosphamide is also very important. If they've reached their cumulative lifetime dose, you really can't do it anymore. This is more important in our ANCA patients, yeah. I think that shows up more. But that's also important to keep in mind. Our pediatric colleagues in nephrology are very well aware of this. They will very commonly in their teenagers with really bad, just raging lupus when they first come in, they will go ahead and do urolupus or even NIH, depending how severe it is, going in, really without too much of a discussion about their fertility, just because of the fact that they're in their teenage years and they have a decent amount of ovarian reserve. So it really, the age component of it does matter. And all of the things that a gyn and reproductive endo can offer us in terms of fertility preservation, they really require a lot of planning and forethought. Mm-hmm. And in most instances, when you're talking about using IV cyclophosphamide, you don't have the luxury of time per se to do all those things. So while it would be great, you can, to start those medications ahead of time and get on Lupron and things like that, practically speaking, it's difficult to accomplish.
And I would also say, practically speaking, having had experience starting patients on cyclophosphamide in the hospital and then trying to continue that, a lot of our patients come from really far away in order to be seen by us at Tampa General. And it just gets really difficult to arrange, even for patients who are seeing us at USF and we need to continue their therapy. It's every 2-week infusion by URLM protocol. Mm-hmm. And I've had patients who could not get their infusion because insurance doesn't approve it, because something, impairs that, and they get readmitted with a severe flare. So practically speaking, CellCept is also much easier because patients can just take it at home anytime. Yeah. And it's not terribly expensive. We can help them pay for it, like Tampa General Patient Pharmacy. So it's just, practically speaking, it's an easier choice for a lot of our patients.
Yeah, and we didn't get into the dosing frequency, but that is the major difference convenience-wise between urolupus and NIH. NIH is every 4 weeks, which for some people, depending on what's going on in their life, may be more practical. Excellent question. Thank you, Dr. Basile.
Thank you. Thank you so much. Great presentation.
Thank you so much.
Anybody else?
I think so too. If you guys have any additional questions, our emails are in the PowerPoint. I mean, you can easily find us by our names too. So thank you so much.
There's only one of each of us.
There's only one of each of us, yes. And thank you so much for letting the fellow do grand rounds. That was nice and a little scary, but really appreciate everyone's participation. And I hope you guys have a great day and a good weekend ahead.